Welcome everyone to today's webinar, Stand Up to Parkinson's, a fall prevention guide for people living with Parkinson's. Today's webinar is facilitated by the Loop Fall Prevention Community of Practice. My name is Michelle Dukeman. I'm the manager for the Fall Prevention Program at Parachute. I'm going to go over a few housekeeping items next, but while I do that, we'd love to see who is joining us today. So if you can, please let us know your role, organization, and location, and that will give us a good sense of who's joining today. All right. Time for housekeeping. During the webinar, if you have questions about the technology, please type them into the chat box. My colleague Marguerite will be monitoring this space. If you have questions for our presenter about their presentation, please submit them through the Q&A box that appears at the bottom of the Zoom window. Questions for our presenter will be answered at the end of the webinar. You'll only be able to view questions you have asked and not questions posed by other participants. The webinar is being recorded, and a link to the recording will be sent to all participants in a few days, along with the link to the presentation slides. As a reminder, the recording link and presentation slides will be posted on Loop in a few days. I know we get that question a lot, and you can access presentation slides and rewatch all Loop webinar recordings on our website or on our YouTube channel. So the link is there for you, but also, of course, that link will be shared in the post-event email. And in case you missed it, on the Loop discussion board or in our newsletter, there is a new Loop evidence summary available. The impact of ageism on physical inactivity and fall prevention among older adults. You can access the evidence summary by visiting Loop, and I'll include it in the post-webinar email as well. All right, I'd like now to introduce our presenter for today. Dr. Nicole Acera is a physiotherapist with a passion for neurological and vestibular rehabilitation. She has 24 years clinical experience treating patients in acute and outpatient settings across Canada, the US, and Australia. Nicole currently sees clients through Vancouver Coastal Health and is clinical faculty at UBC and teaches courses to physiotherapists. You can find a complete bio for Nicole on Loop. So without further ado, please take it away, Nicole, and I'll let you start sharing your screen.
Great. So thank you. Let's see. Is that working there?
Yep, looks good.
Great. Okay. Hi, welcome everyone. Looks like we have a room of physios, which is fabulous, but hopefully some of our OT colleagues and others will join us as we go through our session today. And many of you will see Parkinson's patients in a wide range of settings, of course, because these folks fall so often they may end up in acute or through the needing home support or eventually needing long-term care. So I'm sure many of you will see them hit and miss in your journeys. So with no further ado, we'll go ahead and get started. As you know, falls are very serious business. They can happen anytime to anyone and anywhere. About 30% of adults over 65 fall annually, and around about 85% of all injury-related hospitalizations for seniors are fall related. Sorry, I'll just move my little screen there. The cost of the healthcare system is around about $2 billion a year Canadian, or 500 per senior citizen. So it's actually quite a challenging area as we have an aging population, of course. And falls can lead to a permanent loss of independence, as we know, and a change of home setting. Actually, just recently I heard something on the CBC that was on the Current. There was a journalist in Ottawa who wrote about her experience with her father, who had a fall in I think it was in the lineup of a bank, perhaps. He was otherwise healthy, and it sort of quickly tracked his journey through the medical system, and he ended up passing away as a result of this fall and the sequelae of how things fell apart. I would encourage you to read the article or to listen to the Current. It was a really interesting and unfortunately a very common story. I've spoken to a lot of colleagues, and we all agree this is what happens to a lot of our patients, in particular with Parkinson's patients. This is a path that they can quickly go down. So our role in fall prevention is actually really important. So specific to Parkinson's disease, it's more common after the age of 60. And so there's already the comorbidity of age going on there. Every study is a little different, but it's typical to see age match controls as being double the number of falls, around 60 to 70% per year. And at least 50% to 2/3 are often reported as frequent fall or repeat fallers, I guess. Some studies try to put numbers to these things and say that people will fall maybe 4 to 6 times per year, but I definitely know people who fall in daily, and seen that reflected in the research. And there's a higher rate of injury per fall. For example, people with Parkinson's have been found to be 2 to 4 times more likely to actually sustain a hip fracture in a similar fall. So they're quite a big deal. Just for today, we'll talk about Parkinson's disease itself, which is the second most common neurodegenerative disorder after Alzheimer's disease. Parkinson's was first identified in 1817. There's a lot of evolving information about the nature of this disorder and how the changes in dopamine change and what impacts that has over time. The disease itself affects about 100,000 Canadians. There's no single clinical test for diagnosis. It is still a clinical diagnosis at this time. And you will see, depending on your work setting, Parkinsonism, which could be present for a number of different medical diagnoses. The Parkinson's plus syndromes, like your progressive supranuclear palsy, for example, would be a common Parkinson plus syndrome. There's 3 of those. There's the drug-induced Parkinsonism, which you might see after certain medications or drugs people have taken, and vascular Parkinsonism. So all of those cluster of conditions will present with reduced dopamine in the basal ganglia, and they will present with a large number of the motor and non-motor features that are similar to Parkinson's disease. So just a quick recap of Parkinson's, of how people will present, the symptoms that they will have. The ones on the physio side that we're definitely the most familiar with is the motor features. So the bradykinesia, the hypokinesia, the akinesia, so the slowness of movements, these small movements, the rigidity, the tremor, the dystonia, the uncontrolled, sometimes a larger amplitude, writhing movements, the dyskinesias, the postural instability, lack of balance, and which you can see in standing and also in gait disorders. The freezing of gait and the weakness in their lower extremities in particular are problematic from a falls point of view. So these are the things that we definitely think of as being the biggest features of Parkinson's. But the more time you spend with people with Parkinson's, the more you start to realize how much the non-motor features really affect their day-to-day function and their energy and their falls risk. So everything from sleep disorders to cognitive impairment, depression, apathy, anxiety, fatigue, all these, the postural hypotension. There are a large number of sensory impairment as well. All these different features of Parkinson's actually can be really challenging and can impact people's ability to maintain their balance and to prevent falls. For those of you who don't work with Parkinson's all the time, because there aren't very many movement disorders clinics, it might be worth considering looking at having like a checklist of conditions that you might want to ask people about. In your intake, everyone's would have their own list. I know the Parkinson Society of British Columbia, we worked with them to make a symptom checker list that they have freely available. You can download online, so it's a patient symptom checklist on the Parkinson Society, so the Parkinson Society of British Columbia, PSBC. On their website, they have a free download for people to do a survey of their symptoms. We encourage people to do that for their annual appointments with their neurologist, but it might also be helpful for you when you're assessing your patients and getting to know them and their specific falls risks. And so that takes us right to the falls piece. So what are the risk factors specific to people with Parkinson's or PWP? Well, 3 of them crop up the most commonly. Some people have called them the critical factors in fall prevention, but I have to say every research study kind of comes up with its own unique blend. The 3 most common ones are a history of falls in the past 12 months, the freezing of gait. slowness of walking speed, that's actually calculating speed, like that's a bradykinesia and the slowness of speed. Those three definitely are your biggest predictors of falls. However, other issues of consideration or disease severity, because of Parkinson's, even with well-controlled Parkinson's, the balance reactions tend to deteriorate behind the scenes throughout their life. So this is disease severity or time since diagnosis, fear of falling, balance deficits when you're actually doing your assessment, impaired mobility, reduced lower extremity strength specifically, and cognitive deficits. Those are probably the ones that I probably listen to the most, but they're all really important, of course. So what we did to support people with Parkinson's living in the community is the Movement Disorders Clinic and myself here in British Columbia, we paired with the Parkinson Canada to make a really nice handout. There's a 60-page book. And what we did was each of the different sections does a little bit of a survey of the different high risk factor areas. So you can see them in color around the word risk factors. So medications, physical issues, home environment. And we kind of go around the loop. And so that book is freely available for you to download. And you can request a paper copy of it. It's a really quite a nice book. I've got a copy of it. It's quite a nice book. You can use that. There's also a webinar that's a little bit similar to this, but maybe geared more for caregivers and for people living with Parkinson's that you can always refer people to for education. So maybe that's helpful for you in your setting. So what I've done in this talk is I've mirrored this talk to the other one in terms of doing a bit of a survey of some of the ways that we as predominantly physiotherapists, but as a healthcare team, can support people to prevent falls at home or in their setting, whatever setting you find yourself in. Okay, so the first thing, of course, is to do an individual fall assessment with your patient. And that, again, the assessment is going to vary quite a bit. If you're in an emergency or acute setting, or if you're in a rehab or outpatient setting, it's going to look quite different. I would definitely encourage you to look at the clinical practice guidelines and the Cochrane reviews. I have them listed at the end of the talk, but they may help you bolster your assessment form, because I find that most of the time, if we have it in our assessment form, we ask, and if we don't, we sometimes forget it. So every once in a while, it's kind of good to take a look and make sure that the questions you're asking in your assessment form are capturing everything you want to know to try to help this individual prevent falls based on their individual risk factors. So starting with your history, you're going to take your history, your subjective history, an assessment. I ask a lot of questions about falls and a lot of questions about near falls. It's amazing how much you can learn, how much of a theme and pattern you can see. Maybe, for example, it's related to timing medications or certain time of day or with certain activities or in certain settings. And also getting a really clear picture of the motor and non-motor features that this person is struggling with on a day-to-day basis, and how you may be able to support them with that. And then moving on to your objective assessment, I always start with posture. The rigidity and the forward posture can really, really impact people's flexibility and mobility. It actually can add to the slowness of movement, and it can free up movement to deal with things like tightness in the chest and trunk. Looking at tremors, dystonias, dyskinesias, a lot of people are actually very functional with their dyskinesias. They may have a marked dystonia, but they may walk well through it, or they may actually transfer well through it. So dystonia doesn't mean you can't walk or can't exercise, but it can sometimes play a role in timing and when you do your exercise sessions, and maybe they need to be supervised, for example. Sensation, somatosensation, proprioception. A lot of these folks will have changes in proprioception and kinesthetic sense of where they are in space. So that may translate to things like proper footwear, or advice on managing their diabetes so that they've got optimal sensation in their feet, for example. And then, of course, looking at strength, endurance, and balance, and a bit more on that in particular. I think the balance in particular is a challenge. Looking at postural reactions, as I mentioned, they will deteriorate over time, so it's important to keep that in mind. Static and dynamic balance. Observing any gait disturbances, what are you seeing? Are you seeing freezing of gait? Are you seeing fenestrated short little walking steps? Are you seeing, half turns when they go to sit down and not completing a turn? What are you noticing when they walk and when they do functional tasks? I always check the impact of dual tasking with people with Parkinson's. It's incredible how quickly they fall apart, even with something like, counting or holding up a cup of water. We do have formal tests for these, of course. We have excellent outcome measures that you can use for standards built into things like the mini best test even has that built into one of its you do like a tug and then a tug with dual tasking. So we do have excellent outcome measures you can use to measure that. But I think really it does give people and family members and caregivers insight into why, maybe why someone fell. So it could be that someone was taking a cup of tea to the couch and they fell doing that or something. And people don't understand why walking while holding a cup, you can see such a change in the walking pattern. So it can also be really instructive and informative for family members, caregivers, and loved ones to really see that in the clinical setting. Clocking gait speed. The other little piece is mobility aids. Of course, as a physio, I'm super quick to think about what mobility aids are useful in this setting, but I have to say there are times where people with Parkinson's are significantly worse with a walking aid. And it can be a real challenge to deal with that. And sometimes you have to use go without a walking aid. Another one that'll sometimes work, strangely enough, is like a platform walker, something totally different. For those of you who are working in a hospital or long-term care settings, you may have access to different, different options that may be something to consider. In an outpatient setting or in a home setting, I like to also use composite measures. The mini best test is really an excellent guide. What I like about it is it gives you a little bit of a understanding about which of the 6 kind of key areas that construct balance are in deficit. And sometimes it really stands out that one is the real rate limiting factor that's impairing balance, and it can help you zero in your treatment technique so that people can be as independent with their exercises and falling less often. And that would be really helpful. It's always helpful. So the goal of this assessment is to understand when the person's falling and to see what you can recreate in a clinical setting so that you can target what interventions, strategies, or tools or exercises you can give people to prevent falls. We won't stop all falls, that's for sure. So the goal is to come up with a problem list, and it's going to vary person to person. This is not a complete list. That's not meant to be. It just might be, these are the things that you've noticed for your patient. Maybe they're stooped, do they have a rigid posture? Maybe there's vision changes that came up in the history that you know about. They may have blurred vision or double vision, or maybe they have a cataract they haven't addressed. Pain is such, as you know, for all the other talks I'm sure you've heard about within Loop, is that being in pain increases falls risk. And a lot of people with Parkinson's will have pain also. And with age, people can have challenges with pain. So addressing pain can be, surprisingly valuable. It could be something really specific, like turning in small spaces. Things fall apart in small spaces, but they otherwise do really well. It could be as specific as that. It could be something more general like walking speed, which is a really common one, or balance reactions. It could be other non-motor issues like fatigue, energy, sleep disturbance. These are other things that might be helpful for you to address or for you to refer out to colleagues like occupational therapists or other healthcare team members that can support with the other non-motor features of Parkinson's. And then this dual tasking piece. Really gaining insight into that is a really big help, makes a huge difference for folks. So I like to think of it as like a personal action plan. In that booklet I talked about, the Preventing Falls with Parkinson Canada booklet, it does have at the back, what's my action plan? What am I going to start to work on? You can't do everything at once, I know, but trying to come up with a list of things that you want to start targeting. I guess hoping that falls aren't going to happen doesn't work. Having a bit of an action plan and starting to address things one at a time can really start to make a big difference. So that's what we encourage people to do. So based on your clinical assessment and the falls risk, you want to customize your treatment. I can't say that enough, how important it is for it to be customized. I really try to make sure that my suggestions align with the person's values and their goals. You've got some people who are still working, other people who are grandparents, other people who are, big athletes. You want to try to support them with their interests, and that's really important as well. I find it's really important to involve caregivers and families, especially with disease progression. As people are, where family have to provide more of a caregiving type role, a bit more supportive role, or as people go into, long-term care settings, for example, it's really important that the team is aware of the strategies that you're implementing. So if you're telling someone a strategy for how to turn safely and sit in a long-term care setting, the whole team needs to know it. It isn't just a physio knowing this information. You have to tell the family, anyone who's walking the person, care staff, the nurses, the whole team needs to be on board. Another thing that might need to be addressed kind of head on is stigmas such as mobility aids. If you decide someone does walk better with walking poles and they want to be independent, say with walking poles, there's nothing wrong with that. But for you and me to say that sounds easy, but some people with Parkinson's, there are some, of course, we're all unique individuals. And so there's certain tough pills to swallow for sure for some individuals, but also their perception of risk tolerance might be different than yours. And so you may have to have a conversation about, living at risk and what that might look like, or the stigma around being seen as having a mobility aid, because sometimes this, of course, is the first time people have had to use a mobility aid. You might need to consider realities such as transit. So if you're suggesting someone gets to an exercise class once a week or 3 times a week, well, how are they going to get there? Do they have the supports in place for that? Is it something they can afford? Is it something that works with their schedule? Does the class time work with their medication schedule? So these are the things you may need to also consider. One of the things I always encourage is encouraging self-management and empowering families to manage, the people living with Parkinson's and their caregivers to manage the issue on their own as much as possible. And it may involve also including other online or local support options. There's a lot of Parkinson's associations that have support groups or walking programs or different ways that they can connect with other families. It can also be really helpful. Just a quick reminder that whatever strategies you give them today may not be relevant in 6 months or a year or two. People will outgrow them, and also they can change, what's helpful, what strategies are helpful to them. So you might give one cue for freezing of gait that works today, and in 3 or 4 months, it becomes too automatic and it no longer works, and you need to try a new strategy, which I'll talk about more coming up. But just a reminder that any plan you come up with may need a review. So a lot of people who live with Parkinson's in the community, it'd be wonderful if all of them kind of saw their healthcare team once a year for an annual review. Of course, I would love that. But that doesn't always happen, of course, depends on your setting, but that would be wonderful. And for those of you who are working in places like long-term care, you have to do an annual assessment. So that might be something that's already built into your practice. But you can look into that. Now, again, with that, the 60-page book about falls prevention at home, it goes through the different categories. So I'll just talk a little bit more about fall prevention with some of these other areas, because some of them are also non-physio related, such as medications. Medication, like pharmaceutical therapies, are absolutely the cornerstone of Parkinson management, without a doubt. That said, even with excellent symptom control, postural reactions will absolutely worsen over time. Behind the scenes, they will still continue to have an increased falls risk as time goes on. So making sure that you're aware of that and that patients are aware of that and their caregivers. So medications should be delivered on time, every time, as prescribed. And that's just got to be something that is addressed. I know sometimes when people change from being at home to in hospital, or when they go from hospital to like a rehab center or a long-term care setting, if that's where they land for a period of time or permanently, sometimes those get jiggled around. It's really important to try to advocate for these patients. So as the physio, you might need to bring it to the team's attention that, what were the medications before, and if there's been a change, especially if you're noticing challenges with, getting up or mobility or toileting or whatever in the new setting. So another thing to be aware of is even with excellent medical control, like control with medications, some people are impacted in various ways. Most people have wearing on and wearing off times associated with their with the medication. So the medication kind of builds up in their system. They've got like this peak therapeutic dose, and that's often ideally the perfect time to do things like exercise, and then they will start to wear off. And physicians will reassess whether they can tinker with the medications that they're using so that their regime smooths out their day, or they have the medication closer together. Of course, if they do them too close or if the dose gets too high, you'll see a lot of dystonias. And those can be very problematic for walking. So, it's not just about more medication, it's about, a careful review to make sure that it's optimized. So if someone's falling at certain times of the day or they're having difficulty getting out, they may need to consider what time of medication they're given. So they may need to get their medication delivered to them in bed at 7 in the morning so they can get out of bed for 9 o'clock for breakfast, let's say, if that's, depending on what their scenario is. The impact of dystonia on falls, the need for change over time, especially with disease progression. And the timing of medication. So for example, as I was giving an example before with exercise sessions, an annual review is an excellent way of kind of addressing these issues and keeping on top of it. When I did a literature search for falls related to medications, there really hasn't been much change in the past 5 or 10 years. There are very few studies that actually directly affect medication from like the pharmaceutical approach and falls and how they're related. Often the falls are like a secondary outcome or not really mentioned at all. They might focus more on other motor features or non-motor features of Parkinson's. And I think deep brain stimulation, despite the fact that it's becoming more frequently used, we're kind of in the same boat. There's not a lot at the moment that really gives us great insight into the optimal dosing to try to help prevent falls. With the advent of more home monitoring and body-worn sensors, I'm kind of assuming that will change over time. For your individual patient, a symptom or medication diary can be really beneficial. They are trying some novel approaches to try to deal specifically with fall prevention. I mean, even with deep brain stimulation, they're looking at new areas to target, for example. And there's a few different medication regimes they're looking at that might further impact falls and freezing of gait specifically, and that might be helpful. Just one last comment about medications, and that's the disruption for hospital admission is really a big deal. I know one thing that the Parkinson Society of British Columbia has is they have like this little, like a kit, and it has in there a list of like, these are my medications, and it's got like the timing and the medications that they take. I think that you actually put the medications in there as well. It's almost like a little rescue kit you grab with you when you take someone to hospital. So that when someone is admitted to hospital, their regime is carried over as quickly as possible. Because the challenge, of course, is when you admit someone, let's say someone falls, they break a hip, everything gets totally out of whack while they're waiting for their consult. They're waiting to get the medication from pharmacy. They're trying to connect with the community to make sure they've got the right medication list. And then, of course, the timing's all off, and then they might have surgery that they're waiting for, so they may not be able to take their medication. So oftentimes, that actually is quite disruptive for people who are living with Parkinson's, to try to get them back on track as quickly as possible. So keeping that in mind could be really helpful for a lot of individuals. And actually, the story at the beginning that I talked about the journalist who shared her experience of her father's fall, it sounded in the story like he had an acute delirium in his hospital admission, and he was sort of stuck in a pattern of being stuck in the emergency room for a few days before they were able to manage his admission and what happened. And it sounded from that story like that set him up for failure for the whole rest of the journey. Being stuck in bed because of Parkinson's, because they don't know how to get you up, can be a really, really big deal. Bed sores happen very quickly. It only takes a day or two, especially on a bed that isn't even meant to be a bed. A stretcher isn't a real bed. Those kind of scenarios are a big deal. So the faster you can get people their Parkinson's medication, the faster they can get up and toilet, even within their acute setting. So keep that in mind for those of you who work in emergency departments and acute settings. And for those of you who are consulting with people who are living with Parkinson's at home, get them to have a plan for admission. You basically, if you have Parkinson's, the probability of going to hospital at some point due to a fall is very high. You sort of need a plan for that. Other issues that can come up can be other medical illnesses not related to the Parkinson's at all. So of course, new medical issues can impact anyone at any time. You could get a bladder infection or a cold or a flu, anything could kind of crop up. It can impact energy, cognition, and Parkinson's symptoms. Sometimes these folks end up being a bit bedbound a bit longer than necessary. It can affect the efficacy of their medication and can increase falls risk. Ongoing other health problems can also impact daily symptoms and fall risk. For example, we talked a bit earlier about pain as it relates to Parkinson's. But you could also have pain related to something else like arthritis, and that could increase falls risk. So ensuring that people with Parkinson's are aware of how their concurrent medical conditions affect their symptoms and planning around that, considering how to keep active while maintaining safety at that time. Are mobility aids needed at that time? Perhaps they're kind of on the fence with a mobility aid and that maybe that's helpful, or maybe they need supervision when normally they're independent. And consider how to gradually return to exercise or previous activity levels and mobility as quickly as possible once the new medical condition or the ongoing challenge has been addressed. Another issue is taking unnecessary risks. Now, people with Parkinson's, I find, can sometimes fall into one of two camps. Ironically, sometimes even a bit of both. Some people take too many risks. Their risk tolerance is quite high. Other people will avoid moving and they're very, very fearful of falls. Even if they haven't even hurt themselves, just the fear of a fall or a near fall has scared them enough that they're quite reluctant to get up and move and exercise. As we know, inactivity leads to deconditioning and increased falls risk. So it's important to find a balancing act, no pun intended, between moving safely and not being too risky. So I think a little bit of care and deliberate customized messaging can be really helpful in scenarios like this. So with one person, you may have two patients booked back to back. One person might need reminders to exercise with supervision for safety because they're not safe on their own. And then the next person you see might need a bit of a prod. They might need to be encouraged to stay active, to keep active, to not to suffer all the consequences of not exercising. And also highlighting that, exercise can affect the non-motor side, the non-motor symptoms related to Parkinson's. So the depression, the anxiety, the sleeplessness. Regular exercise can also support those symptoms as well. Now, one thing I would say that this booklet that we have for Parkinson's Canada is also helpful for is it gives a lot of practical tips in there. So things like, sitting to dress, using a reacher, and being careful turning and backing up, and being careful not to dual task or rushing of, doing things one thing at a time. These are the types of little cues that can be really helpful. I've definitely had feedback over time that sometimes it's these little tiny comments that actually are the most helpful for people. It's kind of interesting. Another one that you may need to address head on is fear of falling, as I mentioned. So the fear can lead, of course, to inactivity. So it's best way to get over it is to address the fear and maintain strength, flexibility, balance, endurance through exercise. And as a physio, you can support people with specific exercises to deal with their concerns or mobility aids or strategies or tools that you can give them to try to help them become more active step by step. Another thing that can be helpful is how to call for like a safety plan for how to call for help if someone falls. So does someone need to have a cell phone on them? Do they have like a medical alert type bracelet or something that they can press? Do they only exercise when someone's in the home with them? So those are some safety plan considerations. Those can give people a lot of peace of mind, and they may allow them to feel more confident to be able to exercise or move more freely in a day. The other one is explicitly teaching someone how to get up from the floor, just the real basics. So in this guideline, this booklet that we have, there is like a 2-page picture on how to get up from the floor. And it explains the step-by-step how to get up. So that can be really helpful as well. Consider protective equipment. Maybe hip protectors are helpful, or maybe headgear. There's different things you might want to consider. And then teaching strategies to deal with freezing. I do find that a fear of falling can be connected to a specific symptom like freezing. So on that topic, freezing of gait. Freezing can last for seconds to minutes, and it's associated with falls. Freezing of gait may reflect a milestone evolution in the disease progression. About 60% of people with Parkinson experience freezing, and it may be appropriate to classify people with Parkinson's as sort of freezers or non-freezers. That's possibly as time goes on, we might find that certain strategies work for one group more than the other. Medication regimes may improve freezing episodes, but also may not. Depends on the individual. So you might want to find out where that sits and what the physician has explored, because oftentimes over time they've tinkered with the medication to try to deal with different symptoms. And for some people, regular exercise improves freezing episodes. So healthcare providers really can help people explore which cues are helpful. So certain visual cues can be really helpful. Lines on a floor, you've got a picture of that there. Using an X on the wall, laser pointers, those are some visual cues that might be helpful. The auditory cues like music, a beat, either someone saying a word like step, 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 or listening to something, music on an iPhone with earbuds. Fewer words and avoiding verbal clutter can also be helpful, just as a reminder, though that's a bit different than giving someone an auditory cue. And you also need to allow people time to respond due to the bradykinesia. There are also mental or internal cues like take a big step or heel strike or right left, weight shifting, using touch. There's a kind of a wide range of options that you can explore. I'll just show you a video for 1 second here of someone who is using a cue. So there's no audio to this. Oh, there's maybe her foot. You can maybe hear her foot if you listen to it online, but just a little video of someone who's moving. So this woman has small movements. These movements could lead to falls. And then she's given a cue to think of big steps. And you can see the impact of that. So you can see that it does make a big difference.
Drinking warm water before bed resets blood sugar levels and reverses type 2.
So sorry about that.
Thousands of people are apparently regaining control of their blood sugar every night as they
My
sleep.
apologies,
by adding one unusual ingredient to a glass of warm water.
I can't move. I can't get rid of this.
If you're type 2 or pre-diabetic, struggling to lose weight, stressing over constant monitoring, or just sick of feeling tired all the time.
That's the thing with the free YouTube.
Because a recent study out of Harvard suggests that high...
Sorry about that. All right. The joys of advertising. So those are just a visual example. Yep.
We're not seeing the slides anymore. We're seeing the web browser.
Okay, let's try this one. Thank you very much.
No problem.
How does that one work now?
Still seeing the browser, at least I am. Maybe if you stop sharing and then start sharing again from the beginning, we'll get back to the slide.
I'll make that one smaller so it's gone. And start again. Pardon me. Okay.
Yep, all good.
Great. So those are some different things you can consider. Again, the strategy is not a strategy for life. Oftentimes you have to change strategies over time because once a strategy becomes automatic, it may not have the same stick factor it had before. It may not have the same influence. So another one is something like the following, which is try these 4 steps. If you find that you're freezing, stop and take a breath, stand tall or sit tall. Shift your weight side to side or forward back, and then do a cue strategy like a big movement. So take a big step, and using a big voice and a big step in your head. As we know, people with Parkinson's will often get quite small. They don't have the feedback cycle makes their movements smaller. It can make their writing smaller, their voice smaller. It can also make their stepping strategies smaller. So these type of cues can make a big difference to get people taking a nice big step again so they can get over a threshold or whatever's in their way. So a couple other things to consider might be visualize where you're going, plan your first movement. Again, putting a cognitive overlay can sometimes break this challenge with automaticity. Focus on something straight ahead, like an X in a wall or a picture across the room, going through doorways or getting into elevators. If you're going to sit in a chair, you might want to concentrate on the arm on the far side, or keep doing a large turn, like overturn, like keep going with the arc of the turn before you sit down. Those are other ones keeping the rhythm going, and those can be helpful. If caregivers are given some strategies and some support, one of the things I find they often talk too much, that I'm constantly talking in this webinar, which is ironic, but short and simple statements work best. Simple word like step, take a big step, that's it, big step. Yeah, those type of things, really simple, can be really a little bit more helpful. And it doesn't have to be a louder voice, but just a simple short statement is often enough. And there's the link if you want to see that video again. Now, another challenge that comes along with Parkinson's is cognitive impairment. Some people may have dementia, they may have a delirium, like a transient state of delirium. If someone has elements of cognitive impairment, you may need to switch your focus a little. So this is definitely true for people where they're trying to extend the time that someone's living at home, but there's a lot more caregiver support, or in a long-term care setting, or assisted living, those type of settings. Home environmental modifications become a much bigger deal, which we'll talk about briefly next. Regular toileting, medication optimization, sometimes people are switched to a family doctor as their disease progression worsens, and that which can be a bit unfortunate, because often neurologists or specialist movement disorders specialists might actually have some more creative ideas on how to keep people active for longer. So maybe advocating for that when it's appropriate. Some people will focus on vitamin D as a physio. Clearly, I don't give that, but just for bone density, and looking at other ways to keep their bones strong. Involvement of caregivers, giving them the appropriate strategies and cues, protective equipment, and the possibility of a mobility device. Now, sometimes with dementia, of course, they may resist, or they may not think that the walker is theirs. They may politely hand it back to you, thinking that you've given someone else's walker to them. So teaching new tricks like learning to walk with a mobility device can actually be challenging as the dementia worsens. So sometimes introducing things a little bit earlier can be helpful as well. Keep that in mind. So for home safety assessment, a customized plan to deal with the challenges of one person's home versus another. One person could be living in a one-bedroom condo, and the next person could be living in a multi-level home. So you'll need to customize it to the actual setting. Lighting is clearly important, just like anyone for fall prevention. Keeping regular items within easy reach, installing handrails, grab bars, smoke detectors, avoiding trips hazards, like by removing them, rugs and chairs, and moving anything that's on wheels, which of course is a challenge in a hospital. Ensuring everything's in good working order, wiping up spills when they happen, considering the personal alarm idea or having a phone nearby, and then what strategies they need in their home. So if a certain threshold trips them up, no pun intended, or if they're having difficulty with a strategy like rolling in bed, you might need to specifically address those issues. The Parkinson booklet that I've talked about a few times now also has some nice pictures of the house and kind of how to make some changes in the house itself. So you can see there's downloadable pictures and whatnot that may be helpful for some individuals. As a clinician, of course, you're going to want to tailor those messages, but that can be helpful. And then also their community, for those who are still living at home or in assisted living, where they can still get out into community and participate in activities. Walking aids, are those needed? knowing where the handrails are, shopping, how to kind of navigate all those different situations. When it's safe to still go outside, would they benefit from a traction device on icy surfaces? What are the strategies that they need for footwear? Popular places to rest en route. So again, this booklet has like a picture of a community and just gives some tips on kind of things to do, things to consider in their individual home and setting. Also addressing what to do after a fall, teaching someone how to get up from the floor, and encouraging healthcare teams, encouraging people to talk to their healthcare team when they've had a fall so they can learn from the fall. Those are a really good idea as well. And so the thing that's nearest and dearest to my heart, of course, is the exercise in Parkinson's. It's considered a form of medicine. Some people say you should do 60 minutes of exercise a day for Parkinson's. This is a cute video if you want to watch it, a 9-minute video about why exercise is medicine for people. For older adults in general, we have the ACSM guidelines and Canadian guidelines as well on exercise. And so most of them will recommend 150 minutes or more of exercise a week. Strength training, some of the guidelines will recommend flexibility or balance training as well. There isn't an exact guide for Parkinson's. Do keep in mind that exercise, for anyone, including you and me, we can hurt ourselves. We can have an adverse event related to exercise. Most of the studies actually don't report any safety data. About half of studies don't bother reporting safety data. That said, the other half that do tend to report that exercise is overall very well tolerated and that graduated exposure may be helpful for some individuals who haven't been lifelong exercisers. But there are some reported incidences of falls and minor injuries and some joint muscle soreness and some lightheadedness and dizziness. So do keep that in mind, especially if someone doesn't have a history of exercising. Our understanding of physical activity is it supports Parkinson's with preventing falls, with neuroprotection and helping them with compensation. So it's helping them at multiple levels. So consider how you want to tailor the message for the individual. What kind of education do they need? If they're a lifelong exerciser, maybe not so much. If this is new for them, they might need a little bit more support and encouragement. What type of community integration supports can you provide? We had the physical activity line, which is now in British Columbia, has been rolled into the 811 phone number. So if you're in British Columbia, you can call 811 and get excellent information from a kinesiologist Monday to Friday on exercise groups in your community. So like free walking programs and where there's a heated pool, that type of information. Those can be helpful. So you can find it where you can what you can do. Some healthcare authorities keep lists of that type of information for discharge from programs. You can take advantage of all those. And considering what type of exercise the person would like to participate in a perfect world, they would do aerobic training and strength training both, and balance activities. In a perfect world, they do it all, but not everyone will. And then should they be doing any Parkinson's specific exercises to deal with, say, big movements or freezing of gait strategies, for example? So things to keep in mind are what motivates the individual, what areas of weakness came up on your assessment, what barriers or opportunities does this person seem to have based on where they are in life, and what's available, motivation and interest. A lot of people with Parkinson's will have depression, anxiety, and anhedonia, like difficulty feeling joy. So it can be a little bit tricky to tap into motivation for some people, but it's worth the effort to try to help them navigate that. Consider safety considerations, footwear, getting to and from exercise classes, or if they're online, are they tech savvy? Keeping hydrated, those kind of practical things. Also the possibility for social connections and for an exercise buddy, that can be really helpful. And considering how people would want to monitor things. Do they want to have like a daily calendar or their family wall calendar? Do they want to have an app or a fitness tracker, like one of these heart rate monitor type things? What do people want to do to track themselves? In this guidebook, I made something called my fitness style, which was just a thing I just made up. You can call it whatever you like, just to help people talk about, well, what could you do for aerobic activity, for strengthening, for balance activities, and to maintain your flexibility. And I like to try to be really specific. I try to be collaborative and provide a prescription on frequency, duration, intensity for each of the activity types that we talk about and we decide are our goals. I encourage people to have fun. I just think that it really makes a difference for long-term engagement. The hope is that exercise becomes a lifelong part of living with Parkinson's, and finding things that they stick with over time. It'll be easier if it's fun for them. Just a comment at the bottom, I just say that activities can change over time. There's nothing wrong with that or with the seasons. I know I cycle in the summer and I cross-country ski in the winter. So for me, it changes over time, over the year as well. So it wouldn't surprise me if that's what people would like to do, because I think that's what I would want to do as well. And consider as well how you can maximize learning, which is also great for the cognitive side of Parkinson's, to physical effort, the emotional engagement, the attentional focus, and the cognitive engagement. These can be really helpful as well. And there's no limit to the types of exercises that someone can do if they're capable. There are a number of fabulous organizations like Dance for Parkinson's and Rocksteady Boxing. A lot of them have online courses that people can attend, or like podcast type things they can attend, or they have DVDs that they sell that people can have and play at home. So it could be that someone, purchases a $20 DVD and that's all they use. That's great. Same with things like yoga. There's lots of free stuff at the library, and there's lots of absolutely fabulous stuff on YouTube. There's lots of junk and there's lots of advertising, but there's also a lot of really good ones as well. So helping people to find something that they find enjoyable can be great. Tai Chi, Qigong. Those are excellent ways of incorporating learning something new and balance activities, for example. So trying to think of those different areas, cardiovascular, strength training, the balance and the flexibility, and trying to look at these types of, this is like a menu of sorts of things that they might want to consider. The research has been clear about one thing, is that no one exercise program is the bomb. It's not one of them is the best one. I think the real ticket is for you to help someone find something they like, they enjoy, they can afford, and that brings them joy, and perhaps other ways other than just the physical side. It could be social connections or whatnot as well. So just in summary, I can't emphasize it enough, the importance of a customized assessment, and looking at the individual risk factors and customizing your treatment program. What type of education should you give? Should you be looking at certain equipment? What exercise advice and prescriptions can you help guide people towards? Should you be suggesting a medical review by the physician or the gerontologist, the neurologist, the falls team, whoever's appropriate? Managing cognitive impairments and the non-motor features of Parkinson's, and who do you need to help people navigating the medical system is a really big deal. So, if there's a great OT that you can refer someone to, fabulous. Please do so, because they may not be aware that they even have those services available. And then what environmental modifications can you make, whether that's a home or long-term care? What kind of changes can you make to the setup and where you're working? Then some guidelines, the Canadian guidelines on Parkinson's, there's the UK guidelines, the European guidelines, and there's an older one, but also still has some good elements in it, the Dutch guidelines as well, that are all freely available for you to download. There's a million research articles on PubMed. You can kind of go crazy, but 3 of them that I found that were particularly helpful were reviewing the Cochrane reviews. They're huge. They're hundreds of pages each. You may not want to print them out, but the Cochrane reviews on physical exercise for people with Parkinson's and the fall prevention with Parkinson's. And there was also a nice shorter review that was done this last year on preventing falls and Parkinson's. It was quite a nice review as well. So thank you very much. I'm open to some questions if you have any, and if not, thank you very much and good luck. This is an awesome population to work with. So yeah, hope you enjoy. Hope it's been helpful.
Excellent. Thank you so much, Nicole. I just want to reiterate to folks that any resources that Nicole shared, they will be shared with the post-event email. So don't fret if you weren't able to catch them on the slide, or if I hadn't shared them in the chat, they will be available with the post-event email. But thank you, Nicole, so much for that presentation. It was such a fantastic, comprehensive overview of Parkinson's and how it impacts the risk of falls. So many great practical tips, which I know everyone is always super appreciative of. We did have some folks share their questions in the chat, so we'll get to that momentarily. I just want to remind everyone that when the webinar ends, we'll be ending right around 1 Eastern time, that you'll be redirected to do an evaluation survey, so please fill that out. We really appreciate the feedback, and we use it to continuously improve on these webinars. But shifting focus to the Q&As that we have queued up, I'll go from with our first one. It says, does quote practicing dual or multitasking, such as walking and counting while bouncing a ball, etc., decrease the progression of this effect of Parkinson's?
Yeah. So my understanding is that the Parkinson's will progress behind the scenes regardless of what any of us do. They will continue to lose dopamine, and they will continue to lose balance function behind the scenes. Their balance reactions will slowly deteriorate to an extent. But that said, if people engage in new learning and they challenge their brain, it does slow down a little bit the disease, the progression of the dopamine loss. So does it stop it? No. Does it slow it down? It seems it does. So it affects the trajectory. And the other thing is also that there's compensation. So people's brains are adaptive, and they can actually compensate and handle more things. So just like there's other forms of neuroplasticity, they will grow their capacity through compensation using other pathways within the brain, and others, they'll recruit more brain areas to be able to do a task. So at the end of the day, those activities are very important to try to slow down the disease progression and in the functional capacity of the individual. So the answer is yes, please keep doing dual tasking. Do challenge people to learn new things, learn new sports, and keep their bodies moving.
Great, thank you. All right, the next question. Wondering if you typically see worsening of postural instability following DBS. They mentioned that they've seen this with many DBS clients.
Yeah, so deep brain stimulation is not a one place thing. They can actually stimulate different areas of the brain. So you will see a change in the symptom profile. So it could be that some symptoms are better and some symptoms could be worse. So someone could have less freezing of gait, but they could have more postural instability. So the medications and the deep brain stimulation can, to an extent, mask some of the postural instability, but as I said, it's kind of still happening behind the scenes anyway. So yeah, so you will see a different patient before and after deep brain stimulation, and they're actively assessing which areas of the brain are the best to stimulate, and they do move the actual stimulation location based on the impact of symptom profile. So it's really important that you encourage people to talk to the physician who put it in, and say whether this is a helpful location, if it's better or worse.
Right. All right. And the next question, asking about a relationship of medication, wondering if levodopa and food pairing, does pairing protein or non-pairing of protein foods and the medication improve the body's ability to metabolize the medication and improve symptoms more effectively?
Yeah. So for some people, yes. So for some people, they have to have it with like a soda cracker or something. Now, if some people are non-responders to that, doesn't matter whether they eat or don't eat or whatever. Other people, it really does matter. And protein can be the other main one. So I think there's the two of them. There's just like a simple carb that some people will benefit from, and others is looking at how much protein they have and how close they have it to the time of their medication. It's something that if you think that someone seems to be affected, that's why these diaries can be very helpful. Getting them to speak to the neurologist about that can be really helpful as well. Movement disorders clinics, to be fair, probably have a bit more experience with these little tricks and strategies. That's something to keep in mind, to be fair. But yes, medication, the time of day, and whether it's on whether they have food or don't have food with their medication can affect uptake and absorption in the system.
Great. All right, we've got 1 minute left, so I'm gonna pick one question from the last four that we have left. And they ask, do you have any suggestions to help Parkinson's patients who are requiring constant bed mobility assistance, especially at nighttime, with turning over or trying to get comfortable for caregivers and the actual patient?
Yeah, so oftentimes big movement can be helpful. So the idea of that concept of big movement, so telling someone to reach all the way across the bed, like right for the grab bar on the other side, like almost through it to the other side, can be really helpful. Oftentimes it's that bradykinesia, that smallness of movement, that's causing the challenge with that. So that would be something to keep in mind. Seeing if that works. And then also just the stiffness. If someone's quite stiff through the chest and thorax, doing some treatment to open them up and stretch them out, having a stretching regime for someone like that can be helpful. I also noticed that there's a question about headgear. We don't have it does say that there's a specific question about headgear. Is there one in particular? The answer is no, there isn't a particular headgear that is the best headgear to use. There's one in the US that I've used a couple times. It's a small, low profile one that's kind of more for concussion, but it could be helpful. It's like a bit more socially appropriate to have it. But no, there's no specific headgear. Other people will have like a big bike helmet style option. There's quite a few different options. Depends on how severe the falls are and where the location is. If it's in the long-term care setting or if it's going to be, out in the community and they're walking on their own. So unfortunately, it depends on the size you're expecting for that.
Excellent.
Yeah.
We got in a bonus question. So thanks for answering that one too, Nicole. All righty. So I want to say again, thank you, Nicole. It was such a fantastic presentation. You'll get to see, if you weren't already seen in the chat, so many kind words from participants. It was a really fantastic presentation. We're very grateful to have you. And I'm sure those who watch the recording after who weren't here to watch it live, they'll benefit too. So thank you again. And I hope everyone has a fantastic rest of their day.
Great. Thanks so much for having me. All the best.